Dr. Heyman. Doctor is an internationally recognized expert in integrative medicine. He's currently the program director of integrative medicine at George Washington University. He's also the chair of our medical advisory board, which to my understanding is the first time it's ever been done in the industry. And Dr. Heyman is also a widely sought after and celebrated speaker around the world on the subject of integrative medicine topics. Without further ado, Dr. Heyman, I'm so excited for what you're about to present. Thanks so much.
Skip, and thanks, Doug. It's always a pleasure to be with both of you, and you know it's incredibly exciting to see how our worlds are finally beginning to overlap in meaningful ways. And I know that with these sorts of collaborations, it's not only what the field needs and demands, but it also reflects the growth in our understanding of what's happening to people when they're encountering the built space that is deeply affecting their health. And for so many years we've all lived in these worlds that are completely isolated, and in some ways looked at as sort of the ugly stepchild of our own fields. And yet we all knew, sort of, based on our own observations and the results of our work, that something more was going on than what we were either being told or what, quote, the standard was. And I'd like to think that, we're all here because we aspire for a higher standard. And we also have, I think, enjoyed a sense of kind of deep observation of what was really going on with our patients and clients in sort of that meaningful moment where it was clear there was more going on in a water damaged building than what we've been told. And finally, I think the science has matured on both sides of the equation to the point where we can make statements with a lot more confidence around sort of what we could kind of empirically observe, but now we can begin to tie it together in much more sort of meaningful ways. And I hope that tonight I can shed some light on what have we learned on the medical side? What is sort of the new science and the new narrative? And, how do I think, as someone who's both an academic, but also on the front lines, treating patients who are clearly sick from their living environment. And hopefully it'll shed a little bit more light on probably what all of you have seen, in your own professional activities to one degree or another. And you might say, yep, he's right. Aha, I can relate to that, as we've all probably spent quite a bit of time with people who are suffering. And at the end of the day, that's what this is about. It's about alleviating suffering and a calling to that. But I joke that I'm only as good as the people that are helping to remediate and sanitize the home. My primary partner in that regard has been Larry Schwartz. And I've learned a lot along the way, on that side of the equation. But what I've learned is that we need remediators and microbial inspectors who are trained to a very high standard. And we need practitioners who are also trained to a very high standard to sort of get the results that, we know are possible. And so what I would like to do is go over a slide deck, and I'm going to be both excited to share all this with you, but I'm also going to apologize a little bit that we're going to have to take a dive into the science of what this is. And for some of you, this might feel a little late in the day to get into some complex topics, but to some degree, there's no way around it. And but the spirit of this, the spirit of where I think this collaboration rests, between sort of the medical side and the NORMI side of the equation is to say fully and finally, we need to build a bridge. And I sincerely hope that with the oversight and expertise of Doug and Skip and the rest of the NORMI group, we can really begin to make a difference. But it means that we have to get on the same page. We have to understand the same science. We need to speak the same language. We need to have the same goals. And I know that, truly and sincerely and authentically, I really want to take a moment to thank Doug and thank Skip and thank Shelley Federico and the rest of the leadership at NORMI who has been able to rise above sort of that sense of where we at and ask the question of where can we be and what's the right thing to do. I am very grateful for their support and their vision. And so that to me is the spirit of, what this means between building the bridge from the medical side to the built side and back. Because ultimately the goal is healthy people in healthy environments. And you can't have one without the other. I am absolutely convinced that not only is there an enormous opportunity for us to do right by the people we serve, but it's also maybe one of the most overlooked subjects in public health and primary care. And I don't say that lightly, but I firmly believe that. I am a family physician by training. I spent 16 years at the University of Michigan. I'm very proud of the academic work and research that I did there to build my academic skill set. But not once was I ever asked to interrogate a patient about the quality of their living space. Not once. And yet, when I see the profound impact that the quality of our living space has on people's lives in profound ways, I think it's one of the greatest failures of primary care. And there's no way we can get to these answers without these sorts of professional collaborations. So why are we here today? What's changed? Why now? Is it just because Doug and Skip and I sat down one day and had a beer and decided it was, hey, we like each other? Well, yes, but it's more that the science has changed. And the science has forced a new narrative that I think demands that we ask ourselves, what is the correct role of us as professionals as it relates to dealing with the built space? And we start with the notion of, well, how big is the problem? And quite frankly, the problem is not only larger than I ever realized, but the numbers are daunting. If we assume that the EPA is correct, that up to 85% of all buildings have experienced some kind of water damage, that means most of the US population, or maybe all of the US population, has been exposed to some kind of microbial event at some point in their lives. And in addition to that, the secondary narrative has been, well, no big deal. What I learned as a physician, and what's still held true today, when you look at the current guidelines in the American Academy of Allergy and Immunology, or the references that are made to governing bodies and agencies. If you look at, for example, the Institute of Medicine, they're still referencing what they believe to be the main clinical impact of this sort of widespread potential for exposure, and that is an allergic response. But what we know is it's now know is that it's probably more than that. But when I enter sort of the discourse with other professionals and medical professionals and academics, they're still referencing guidelines and research from 2004. Even now, when I participate in court cases, the defense experts reference 2004, 2007, 2008. And they say, well, Dr. Heyman, all the guidelines suggest that, exposure, meaningful exposure to a water damaged environment triggers potentially allergic responses. And what that does is two things. Number one, it diminishes the patient's actual experience of what's occurring clinically, but it also diminishes the importance on the remediation side to some degree, because it suggests that if all we need to do is clean up the environment and the allergies go away, this really isn't that big of a deal. And in some ways, both sides of the equation, I think, have been minimized. And yet our own sort of professional experience, I think, would suggest otherwise. And so through sort of observation and sort of empirical data collection and watching people become very sick from their homes that go clearly well beyond allergies, I think we've all kind of known that something more was happening. But again, we've all been sort of pushed to the margins in a sense. And so finally, over the last really decade, the science has matured to the point where at least finally you can go to the NIH website. And if you go to their mold page, sure, it talks about asthma and it talks about allergies, but what else does it talk about? And you cannot overstate the value of this one, what appears to be innocuous sentence, that long-term exposure to inhaled mycotoxins may promote inflammation and immune system changes. Finally, one of the governing bodies has acknowledged a different immunologic process that we now know is much more insidious, much more harmful, much more impactful to organs and tissues than sort of the throwaway idea that, oh, it's just allergies. And no wonder when you're dealing with someone who has a potentially long list of symptoms and complaints, that it's not just being generated by allergic responses, but more importantly, there's this inflammatory drive that's occurring throughout the body systems and organs and tissues. And therefore, we can see the incredible diversity of presentation clinically that these patients might have. The hallmarks are fatigue, headaches, difficulty breathing, digestive issues like abdominal pains and bloating, but also memory loss, mood disturbances, numbness and tingling. And it goes even broader than that to, basically symptoms from every system in every category. To some degree, both because we've ignored this issue, but also the variety of symptoms makes it very hard to identify. One person could have headaches and digestive complaints and neurologic issues, and another person has fatigue, brain fog, and mood disturbances. And so they all might be affected by their home, but they might be presenting very different clinically. And it's one of the reasons why I think it gets missed. So if we look at, some of the literature and just, here's one study I pulled among, countless, published in 2020 that says inhalation of mold causes innate immune activation. So it's a body on fire. And this idea that that fire is just not limited to one organ system or process. But what's interesting, and I think many of you can relate to this, is have you ever been sort of dealing with a client who seems a bit unreasonable, maybe a bit too irritable, maybe a bit too reactive, or just difficult in general? There appears to be a background of anxiety, maybe even depression or hopelessness. They lose faith in you quickly. They blame you if they're not feeling better. They're difficult to manage. Maybe they're not remembering things that you asked them to do or said to them, or they seem very confused at times. And it's easy for all of us to, quote, blame the patient or blame the client. But don't forget, what's really happening in this subcategory of patients is they have a brain on fire. Their brains literally do not work correctly. And one of the things we have become very concerned about in this patient population is what are the end consequences of an illness like this? All of medicine now accepts inflammation is bad for you, and it's bad for your organs, and it's bad for your longevity and vitality. And every study now says this. In fact, we have a term for it. We call it inflammaging, that if you have a background of unregulated inflammation, you will have accelerated aging. And what is, I think, particularly difficult about this population, it is the sort of brain on fire phenomenon. And so our research group started looking at that issue more directly, and we began collecting data using specialized brain imaging. And what we found was striking, that over time, with enough inflammation in the brain can become damaged in this illness. And it's very similar in its pattern to what we see with traumatic brain injury. In fact, I'm now doing another study where we're comparing injury to the brain from mold exposure to injury to the brain from traumatic brain injury. And the overlap in what we see in our MRIs is profound. Make no mistake, if you live in a toxic environment long enough, there is a subgroup of people whose brains will become injured, and maybe irreparably. This is an extraordinary statement, but it's true. And you have to ask yourself, how many people have you dealt with as a remediator, as an inspector, where you could tell something was pretty off with the client? And without needing to be a clinician, that spidey sense of this is someone who's not functioning normally, and this sense of, gosh, maybe I've seen this before in other clients. I would suggest trust your instinct. The patterns that you're seeing are real. And that's part of what we had to do, but begin to apply research tools in that regard. We went even further. And so we opened a research lab in 2015, and we started doing what's called genomics, which is looking at how certain genes are turning on and off in the body relative to this issue. So we have an exposure, we have immunologic reactions that then in turn lead to genomic changes in the body, and all of that together potentially can lead to injury to organs and tissues, including the brain. We are well beyond the notion that this is not a big deal, that allergies are the worst of this, and that all we need to do is kind of get it right with our remediation and sanitization protocols, and everybody should just go on their merry way. It's why Doug and Skip and NORMI have spent so much time and so much effort trying to figure out what is the medical standard of sanitizing an environment. and raising the bar in that regard, because this is mission critical. This is grandma with Alzheimer's. This is dad with Parkinson's. This is your sister with MS. This is your, brother with chronic fatigue syndrome, or your sister with fibromyalgia, or your daughter who has, treatment-resistant anxiety and depression. These are serious, serious clinical consequences that we're only finally starting to unravel. And it also means that for me as a clinician, I have to do the deep dive to better understand where my patients are at. I've got to do a full symptom inventory. I need the help from the best assessors I can find. And then we go through a series of testing to look at whether or not, is this a brain and a body on fire relative to their lived environment? And we have to do blood work. I've got to do genomics. I might have to do brain imaging. This is not only not for the faint of heart, but it's not really what medicine is good at. So much of the medical model is based on looking at, singular parameters and treating those singular parameters. If your blood pressure's up, here's your drug. If your blood sugar's up, here's your drug. If you have rheumatoid arthritis, here's your drug. If you have asthma, here's your drug. But this is a multi-symptom, multi-system illness. And as a clinician, I have to raise my bar and be good at a lot of things to get it right with my patients. And part of that is because if you look at all the diseases that are associated with this inflammatory drive that's established in the body, it's all of internal medicine. It's every body system. I've got to be a neurologist. I've got to be a cardiologist. I've got to be an immunologist. I have to be an endocrinologist. I've got to be a gastroenterologist. The list goes on and on and on. No wonder practitioners have been confused by what they're looking at. No wonder we end up just treating the symptoms and not the underlying cause. No wonder we've missed this from a primary care and a public health perspective. And in particular, if you look at the most common symptoms that patients present with in a primary care practice, and you look at the most common symptoms that we see in patients affected by a water damaged building, they're basically the same: fatigue, pain disorders, mood problems, cognitive decline, digestive complaints, respiratory issues. These are all the things that I would normally see in a primary care practice. And yet we never really ask the question, could it be from the live space? And so we're starting to build this complex pathophysiologic model where there's this interaction that we see between our genes and our environment that's leading to this inflammation throughout the body. One of the things that we've noticed is that we've also had to break free of our sort of dependency on the notion that it's just mold. And now we recognize that when there's water damage or even just high humidity, it's a polymicrobial event. We see the expression of fungal forms, bacterial forms, but also inflammagens such as endotoxins and derivative compounds from the sort of, parent causes. So for example, beta-glucans, which are some of the most potent initiators of the immune response that are liberated from the cell wall of mold forms. But what we're learning is what liberates beta-glucans from mold to stimulate monocytes and macrophages. Well, enzymes that are produced by actinomycetes, bacteria. That actinomycetes make beta-glucanases that potentize mold. And so our awareness is growing that it's not just mold, it's not just the spores, it's the compounds and molecules and sort of soup of inflammatory proteins that get liberated into the environment. And now we've learned we need to test for all of these. we've also, to confirm this, we actually have found, we believe, at least some of the genes that turn on to these exposures. And I'll show you that in a little bit. But all of this has forced us to ask a new set of questions. Does this change what we test for in the home? Yes. Does this change how we remediate and sanitize? Yes. Does this change what we test for in humans? Yes. And does this change how we treat? Yes. That here, finally, we sort of embrace the seriousness and complexity that the topic really demands. And so, again, when you look at the NORMI protocols that have been standardized, they're now asking these questions. And when you look at how we assess and treat patients, we're asking a very similar set of questions. And I think this is reflective of the new science, but also where we're going to get better results. As far as treatment goes, it's not one thing, which that's what medicine likes to do. In my clinical process, there's a series of steps that I have to go through to get people better, to reduce inflammation, to improve metabolic resiliency, and ultimately we end with a very special neuropeptide called VIP. And VIP is a substance that's normally made in the body, but we have found that it does a few very important things. We've also learned that it loses its effectiveness if you use it too soon in the treatment protocol. If the person's house has not been fully remediated, if they're still inflamed, if they're still metabolically challenged, you can give VIP all day long and it won't work. It's got to be given at the right dose for the right amount of time to see the results. And the results we see are reflected twofold. One, we see genes going back to normal, and we also see repair of the central nervous system of the brain. That's extraordinary. And in many ways, the results we can potentially get are counter to what the medical textbook suggests is possible. That when you look at the end result of the illness complex, that you have an individual who's expressing what appears to be Parkinson's symptoms or Alzheimer's symptoms or MS symptoms or what have you, these are end diseases. They're not potentially reversible. But if you get the house right and you get the treatment right, we see reversal. And it's an amazing thing to behold. But all of this is dependent first and foremost on removal from exposure. You cannot get patients better if they're still living in a toxic environment. I joke all the time with my patients, I'm only as good as my remediation support. I can't do my job without a properly sanitized home. None of these treatments work. And so we are highly dependent on each other. I make you look good and you make me look good. Now, to get to this moment, again, we had to do the deep dive, and we took advantage of the new science, the new medicine that is now available to us. And that includes the burgeoning field of omics, which includes genomics, proteomics, transcriptomics, and metabolomics. Paired with that is a growing recognition of the role of prevention and lifestyle and wellness and even traditional healing methods. We've had to bring all of that to bear to get people better. But what's happening on the medicine side of the equation is by virtue of the fact that we're able to now assay 1,000 to 2,000 analytes on an individual and run all of that data through complex algorithms, machine learning, artificial intelligence, we can detect early imbalances in biological trends that are happening across body systems to offer a new model of how we look at patients that's much more personalized, it's predictive, and it's preventive. It's the promise of what I think we've always hoped for, and that is to say a much more individualized approach to medical care. But all of that has been built on this sort of new era of technology and new ability to assess and peer ever more deeply into the recesses of molecular biology of our patients. We live in extraordinary times in that regard. And in particular, this notion that omics is starting to uncover what's there. This has been part of the breakthrough with respect to divorcing ourselves from the notion and dependency on the idea of allergies only into this broader, more complex immunologic model. Now, when I say omics, you might think genetics. And I would say they're separate but related. Genetics really is the study of the inherited genes and their structure. It was codified in the early 2000s by one of my early teachers from University of Michigan, Francis Collins, who was appointed to run the NIH program in human genome. And we thought at the time in the early 2000s, when the human genome was finally codified, that that was it. We solved all of the problems. And we realized over time, though, that however much it was a breakthrough, it was limited. Genetics is really the field of measuring the structure of an inherited gene. Genomics, which was a progression from genetics, instead is measuring gene activity. And this notion that we're able to now measure structure and function is the collective breakthrough. The way I liken it is the human has basically 30,000 protein encoding genes. And to me, genetics is asking the question, if you have 30,000 instruments in your own personal orchestra, were each of the instruments built properly? Does the slide on your trombone stick? Are the keys in your clarinet in the right order? Do you have the correct number of strings on your cello? That's genetics. And the assumption is if you have a gene that's not built properly, if you inherited something that's improper in structure, you will not get the sound production that we sort of expect. You can also just have structural variation. Your clarinet might be a little different than mine, so it sounds differently. I've got hazel eyes and you've got blue eyes. Omics was asking a different question. Omics was saying genetics is great, but what's your music? What's your melody? What's your harmony? Are genes activating and turning on and off at the right time? Is there regulation of gene response and coordination across gene sequences in reaction to environmental inputs? And what we've learned, which is fascinating, is some genes can be playing too loudly and other genes can be playing too softly, that their structure is totally normal, but their function is abnormal. So you can have your woodwind section playing too loudly and your percussion section not playing on time and your brass section playing too softly. And we've now learned that these sort of functional variations stand at the core of many chronic illnesses. And when you have significant inputs like exposure to mycotoxins or inflammatory compounds, they can alter the patterns of gene expression so that the body is functioning abnormally. Nothing wrong with your genes per se, genetically speaking, but there's something wrong with the music. And we don't have melody and harmony anymore. We have noise, molecular noise. This is an enormous breakthrough. And it poses a whole set of other questions of how can we get people better? Now, here's an interesting slide. This is a group of 50 of our research subjects, and we are color coding over 800 genes with each of the 50. And what we're showing is that if it's a gene which is a circle, color-coded orange or red, it's overly expressed. It's a section of the orchestra that's playing too loudly. Normal is purple or blue. Now, if you look at the top, all you need to recognize, it says, the second line says pre-VIP. So what does that mean? This means these are patients who've cleaned their home. They've done a variety of treatments, including reducing inflammation, improving metabolic efficiency, but the one thing they haven't done is VIP, is vasoactive intestinal peptide. Now think about that for a second. These are people that we've all been told have already been treated properly. You've cleaned their home. You've given them some basic therapies like, let's say allergy medications, but guess what? They still have molecular noise. Now, we give them VIP at the right time, at the right amount, for the right amount of time, which is 6 to 12 months. And this is what happens. The genes are re-regulated. They're now functioning normally. And what we've learned is that the primary set of genes that are affected in this illness in particular, which is considered really a fatiguing illness, and it makes sense, is the mitochondria. And we've now learned that this is really truly a mitochondrial disorder at its heart. And it's the genes of the mitochondria that are behaving abnormally that drive the illness complex and these exposure-related illnesses. And it makes sense because the mitochondria are what coordinate the cellular stress response. That when you expose a cell and to a toxin, a virus, a chemical compound, even we think emotional stress, the cell changes gene sequences to stop burning oxygen and start burning sugar. And this sets off a cascade of events where the cell is now in a distressed state, trying to defend itself from these exposures. And we've learned that you can remove the exposure, you can offer a variety of treatments, but the cells also need a push back to normal mitochondrial function. And that push has been things like VIP. So we then ask a further set of questions. If it's possible that exposure can lead to injury to the central nervous system, are there specific neurodegenerative diseases that also fit this model? Is it possible that a mold exposure can lead to Parkinson's disease, for example? So we started looking at gene sequences that had already been identified that are turned on abnormally in Parkinson's disease. And we asked the question, is that same potential true in this illness? Can we see the same set of genes turned on in a subset of our mold patients? And sure enough, we did. And we found 3 sets of genes in particular. We call this a triple positive. 3 sets of genes that if they turn on simultaneously, the risk associated with Parkinson's disease goes up. Now, is this the end of the story? No, it's just the beginning. Is this the final set of genes? No. This is genes pointing in a direction. Does it mean if these genes are turned on, you're guaranteed to get Parkinson's? No. But the pattern is there. And that's what this is about, sort of doing the deep dive to offer up this notion of pattern recognition. So what do those patterns look like? How do I measure those patterns? Well, here is a report from a Parkinson's patient of mine. And we color code these genes, these mitochondrial genes, where if they're blue, they're under functioning. If they're red, they're over functioning. And you don't need to know anything about these categories other than to say, if a clear circle is normal, I can tell you this is an individual who has a deep abnormality in her set of mitochondrial genes. Her mitochondria, her cells are in deep distress as a result of her exposure to a water-damaged building. We can see the molecular shifts that we would expect to see in that population. We can see the excessive inflammation, but we can also, for example, identify the genes that turn on to the environment. These are part of the cell stress signal pathways that correlate to the types of exposures that we now know we can test for in the environment. And certain patterns of gene sequences seem to relate to specific exposures, that there does appear to be an association between a certain pattern in mold and a different pattern in bacteria and a different pattern in endotoxins and a different pattern in beta-glucans. And the more research we do, the more we can begin to tie together known exposure, swab results in a home or air testing with symptoms, labs, brain scans, and now genomics. And we can see at the bottom, section 19 says Parkinson's, all of her genes are turned on, but she had the triple positive. Now, what does she look like 9 months later? Well, if you look from left to right, after she's gone through a remediation process, after she's gone through a series of treatments, including she's now currently on VIP, if you just glance left to right, you can see her genes are starting to go to normal. She's starting to resolve the aberrant patterns of gene expression. This is an extraordinary moment and an extraordinary finding that we have sort of molecular detail around re-regulation of gene response of the mitochondria and a restoration of energy production and cell-to-cell communication, reduction of an inflammatory drive, and improvement of cell energetics in general. Now, one of the triple positives, this is one of the three sections, starting to go to normal. If you look from left to right, you can see resolution. And if you look at section 9 and 10, we can see the improvement in her reaction to her living space, that the remediation techniques are working. And if we look from left to right again, you can see resolution of the disease process, including improvement of her two other triple positive sections. This is a woman who's beating the odds. This is a woman whose neurologist cannot believe her Parkinson's symptoms are improving. She's a 54-year-old female who otherwise had a diagnosis of early onset Parkinson's, who had failed conventional therapy. And she's getting better. This should not happen if you read the textbook. And yet, this is the sort of pinnacle, I think, of the current science today, which is to say we are cracking the code on what is a medical standard for remediation and sanitization, and what is a medical standard for assessment and treatment in these complex patients. And we had to do the deep dive. We had to take advantage of the new science to get there. No more guessing. So let's take a pause. What do we know so far? Research has uncovered an inflammatory model related to a water-damaged building. This inflammation has wide-ranging impact on virtually every physiologic system, key organs and tissues, and even changes in gene expression. What we measure and how we measure is changing. What we treat and how we treat is changing, and that's true for both the home and for patients. Removal does not guarantee recovery, at least in a subset of patients. Some will only have allergies and get better. Some will have other kinds of symptoms and get better. And some, with perfect remediation, will not get better. And it's because their bodies are stuck in this sort of abnormal discord of their genomics, and they've been left with damage to their tissues and organs because of this unregulated inflammation, which has likely gone on for years. And so we have to be better at understanding which patients are in which categories. It's not that Institute of Medicine in 2004 was wrong. It just wasn't the whole story. And by virtue of that, to some degree, I guess I would have given them the hall pass 10 years ago. But here we are 10 years on, and you can find 1,000 research studies on what I'm talking about. So that's where the failure is. It's the professional side not keeping up with the science. And this is not unique to our space. There are plenty of topics in medicine where the science has marched on and medicine is not caught up yet. But this is such a big subject. It affects literally millions of patients. This is not an uncommon or orphan illness in its classic sense. This is a public health threat that affects your family, your loved ones, your friends, your neighbors. This is everywhere. And so, to me, because of the ubiquitousness of all of this, the quality of our living spaces are a vital sign that's never measured clinically. As much as we should talk about measuring a blood pressure or a heart rate or a BMI, we should equally be asking, what's the quality of your live space? Every single patient. That to me should be standard of care. If that ever happens in the future, I will rest comfortably knowing we did our job. We did our job. But to get there, we need to acknowledge that the science is now, and it's sort of, I think, demanding that we respect it and we behave accordingly. Now, I know this is a big ask. So I believe this. I think microbial inspectors and remediators are truly the front line of this illness, probably more so than primary care, because by definition, they're in a home where someone has asked for help. And you might be the first person that even raises the issue of, hey, did you ever consider how you feel and your health status overall might really be deeply affected by your house? That this is not something to necessarily write off. Again, the living space is a vital sign, but here's where the challenge is. I mean, think about it from the medical perspective, right? As a physician, I'm sort of here inside the yellow box of medicine, but look at all the other things that I need to learn to speak this new language of systems biology and omics and wellness and prevention and regenerative medicine and healing tissues and organs. This is like going back to medical school 3 times over. And yet this is what this topic demands. In some ways, I would imagine Doug and Skip are shaking their head yes, saying it sort of feels like that on our side as well. That whatever we learned when we were young and enthusiastic about being professionals in the remediation space, what we now know could fill 3 more textbooks. What we now know is so much more than what we were taught. And we have to sort of, go through the growing pains as professionals. So much of this is being driven by technology, our ability to measure what's around us and inside of us, in addition to all the web services and wearable devices and tethering and rapid diagnostics. That technology is, sort of both the promise and the peril, because it challenges our ability to understand the world around us. And so to the rescue is big data, because we can collect so much information on an individual, we can collect so much information on a live space, but what does it mean? How do you put the pieces together? And what's fascinating to me is, having read as much literature as I cannot find a single clinical outcome study that looked at a population of patients that measured in granular detail the assessment of the home and what the remediation strategies were, paired with what was the assessment of the patients and what were their treatments, and ultimately what were their outcomes. That you can't get to solution without knowing both sides of that equation. And yet right now, there's not a single study that looks at both sides. That's amazing to me, that nobody's ever tried to answer that particular question. I can show you tons of science on the building side, and I can show you now tons of science on the patient side. But it's as if the 2 worlds never want to talk to each other. And it makes no sense to me from a research perspective. We have the tools, we have the technology, but we have to scale the size of our research. We have to scale the type of research that we do. But it means we have to sort of grow into accepting a broader role of who we are as a community that's trying to take on this challenge. So sort of blazing that trail together and accepting this notion of kind of setting a new standard in biotoxin illness, how can we get there? Well, it starts with education. It starts with accepting that we just don't know everything we thought we knew. And we have to acknowledge the science has moved on and sort of challenge ourselves to say, can we step into this new role? And I will say, your role as a remediator cannot be overstated in this problem. And so part of that new role, I think, needs to be a deeper understanding of the medical basics of a biotoxin illness. None of us can get away with saying, oh, it's just an allergy. That's bad science at this point. I would, if you were one of my graduate students, I would give you an F if you said it's only allergies. We just cannot say that anymore. Whether or not the standard of care has recognized that, the science is well beyond that standard at this point. It also, I would say, as you educate yourselves, will help you communicate more effectively with your clients. You will often build trust much more quickly as you acknowledge what their lived experience is in their home, to say, you know what, I'm not a clinician, but I could imagine that your home might be causing some real health issues. And we've seen this with other clients. We know this is real. It can reach into every aspect of a person's health and life. And you might be the first person to ever say that to them. And that's both a burden, but a blessing. And it really is. And I will tell you, when a person is finally validated, when they've been told they're crazy, when they've been told by the medical community there's nothing wrong with them, when they've been told, hey, I think it's mold, or they think it's mold, and they're told, that's not a big deal, you might be the first person to say, wait a minute, that is a big deal. I'm here to tell you it's a big deal. And in some ways, in your own sort of light, non-clinical way, it might form the initial assessment. And to me, that poses the moment of asking the question, when to refer. To finally say, there's help out there for you. And I think that this sort of expanded role of early detection is incredibly meaningful. And it also, I think, poses an opportunity that collectively, maybe we can start gathering data as a group where we start pooling the assessment of the home and the treatment of the home with the assessment of the patient and the treatment of the patient. That, to me, would be the ultimate breakthrough in our field in particular, that the two sides of the equation are finally kind of talking to each other. I would also say, by expanding our awareness of what the total illness complex is, I do think it offers new opportunities, new roles, new sources of income for us, because we're now operating on a different level. And to me, finally, I'd love to see, by virtue of all of us speaking the same language, collecting data, helping people on a larger scale, that we would have stronger collaboration with treatment providers, and that there wouldn't be these silos that are really truly artificial at this point, that the deeper that collaboration, the more we're going to help the population. And the same is true reflected with clinicians. They need to be better educated as well. They need to understand how to work with remediators and inspectors, and to collect data in what we would call a practice-based research network. And if you look on the left, this notion of education blended with tools and technology to collect data and analyzing that data and scaling that information, generating new knowledge, publishing research articles, I think not only means we're sort of, quote, first to market, but it offers continuous quality improvement because we're learning more about what's working, what's not working. And also this gives us an enormous commercial advantage. Nobody would be able to say the things that you would be able to say as an expert remediator, grounded in evidence-based science, proving positive patient outcomes, collaborating with medical professionals, publishing that research, and creating, quite frankly, the new standard. Because I can tell you, there is no funding for this. Nobody is waiting for the white knight, right? If we don't do it, who will? Quite frankly, who will? I can't wait for the allergists and immunologists to do it. They're out to lunch. They're happy to say it's just an allergy. And who knows when the transition would happen on the medical side. At least you have a group the size of NORMI setting a new standard. We don't have that on the medical side. I can probably count on one hand the number of academic physicians who know anything about this stuff. And then, there's a small group of practitioners that care about these things, but their knowledge base is all over the map. They all do different stuff and they all treat in different ways and nobody's collecting data. So this notion of beginning to organize ourselves into a model where we begin to collaborate as professionals, I think makes a lot of sense. This notion of collecting data on the assessment side and remediation and sanitization side for the home, as well as combining that data on the diagnostic and treatment side and creating data funnels and data lakes so that we can determine what's not working and what is working, that we're linking, as we say in the parlance of health services outcomes research, process to outcomes, and that we look to achieve that final end result, which is what we all want, which is healthy people in healthy environments, that there's a real parallelism between what we can do on the NORMI side of the equation with what we can do on the medical side of the equation. And it just takes a commitment to that idea. And finally begin answering the question, did you do the right thing and did you do it right? And ultimately, that's the standard that I want us to set for ourselves, that we can better guarantee positive outcomes for the people that we try and help. Now, what's one of the pieces, concrete pieces, that we are collaboratively putting in place? And this is one among many. And I want to reassure the group that the people who are listening and hopefully feeling a little inspired is that this isn't just talk. That behind the scenes, we're putting the bricks in place to build that new, safer home in a sense. And so we've been working diligently behind the scenes and thinking about, well, what has to happen to start moving in a new direction? And for me, my bias, of course, is you start with education. And NORMI, as an education provider, is well suited to create that new standard. But we're now building bridges. And one of the major bridges is with my university, George Washington University. And for the first time in our profession, we now have an approved course that will educate remediators, indoor air quality experts, students, environmental scientists, research scientists, allied health professionals, microbial inspectors on the basics of this illness so that you can have a deeper and more collaborative conversation with your clients around this subject. When I spoke to the curriculum committee at George Washington University, and I explained to them the science, because that is my job, is to sort of prove that this course is needed. They couldn't believe that this was the first time a course like this had ever been assembled. That was extraordinary to me. And what was not surprising was the number of faculty members who individually pulled me aside and said, hey, I think my home has a problem, or my kid has an issue, or my mom might be suffering from this. Inevitably, it led to that, which you're on the right track when something like that occurs. But I cannot overstate how thrilled I am that the collaboration, the insight that Doug has had to establish a medical advisory board, but to say, what are the concrete steps that have to occur for us to change the field? And so we said, it has to be formalized, that education has to be formalized. And so now we have a partnership with George Washington University, and they hope that, in fact, we expand these educational offerings and further develop out the professional skill set of the other side of the equation. Now, make no mistake, for those, some of you probably had the insight of, well, what is he doing for medical professionals? We also simultaneously have a course now approved for medical professionals as well. So one for the remediator side of the equation and a separate course for medical professionals. But with the collective end goal of not only raising the standard, but building collaborative efforts, collecting data as a group so that we can publish the research that needs to be published. And we also have that attention within the university as well. The Center for Brain Health in particular is very interested in where all of this is going. And so what we're hoping for is that everybody starts to lean in a little bit more to the subject, to embrace what it really is in terms of its potential impact on the individual, how complex the illnesses can be, how serious this is, and how much we might be able to achieve as a network of professionals if we just make a bit more of an effort to collect data, to publish research. And that's the other piece that we're going to be putting in place, is to make it easy for everyone to, as part of the workflow process, collect data. That we don't want it to interfere with anybody's work processes, but we do want to start offering up those tools and technology so that we can start looking at health-related outcomes. The course will be open August 1st. It's self-paced, so you can just sign on. And it should take about 10 hours total, maybe probably less. And you'll get a certificate from George Washington University, which I think is extremely meaningful to say, we are the first group ever to create a collaboration like this. And so my hope is that the expanded role of the remediator and the microbial inspector starts to look like sort of broader education, using new tools and technology to do your job better and more efficiently, but also collect data to enhance professional relationships, especially on the medical side of the equation, but to also see yourselves as first-line therapy for the home and its inhabitants, and to establish a new standard of care. And together, my sincere hope is we can fill the blank chapter in the textbook of medicine to say we did it, we cracked the code, we got together and we figured this out, we took it seriously, and we showed the kind of outcomes that we knew were there. And again, I am forever grateful for this opportunity. I know that each of you have been sort of working in your own silos. You've had the sort of great good fortune of being a member of NORMI and the important sort of role that plays in your professional lives. And now we have an opportunity to leverage our collective resources to really change medicine. And, we're sort of on the verge of that, I think. but it's going to be done together. And we're working very hard behind the scenes to help make that happen. It won't happen overnight, but we have the pieces that I think are required to start moving in the right direction. Education first, and then we'll continue to put the building blocks in place. And, you know, so again, thank you for your time and attention tonight. I think maybe I ran over a little bit. I apologize for that. But I hope this was inspiring. I hope it was affirming. And I hope that this is just the beginning of a long-term collaboration. So thanks again.